Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to the Doc Podcast. Today, I am honored to have the amazing Dr. Rebecca Bockow with me for a conversation about interceptive orthodontic treatment. Becca is world-renowned for her work in the area of pediatric sleep-disordered breathing and interceptive orthodontic treatment. She received her dental degree from the University of Washington School of Dentistry, where upon graduation, she practiced as a restorative dentist in Seattle, Washington. In 2013, she completed her dual training in both orthodontics and periodontics from the University of Pennsylvania School of Dental Medicine, where she also earned a master's in oral biology. Becca is a board-certified orthodontist and periodontist. She is a resident faculty member at Spear Education and lectures to audiences internationally on topics including interdisciplinary treatment planning, airway and sleep disorders, skeletal growth and development, surgical treatment planning, and TAD expansion. And somehow, in addition to doing all of that, she maintains a very successful private practice in orthodontics with locations in Seattle and Bellevue. Becca and I share a passion for interceptive orthodontic treatment and all that it can do for our patients and our practices. We're going to dive deep into that during this episode and talk about some of those concepts and the reasons why in great detail. And whether you do a lot of interceptive treatment in your practice and you want to learn more about it, or maybe you don't do as much and you just kind of want to learn more about how you could start to incorporate it into your practice, you are really going to enjoy this conversation. So with that, I would like to extend a heartfelt welcome to Dr. Becca Bockow. Welcome, Becca.
Thank you so much for having me, and thank you for really getting this message out. I truly appreciate it.
No, you're welcome. And again, as we say all the time when we talk about these things and kind of our circle of colleagues that has started to voice our opinions more publicly, I think the more people hear this and the more people hear that this is possible, and not only possible, but life-changing for our patients. And that's how that paradigm is going to shift. Just the more of us that are there and beating that drum and saying, no, we're not going away. This isn't just something on a whim or a fad. This is based in science. There's a lot of evidence for this. And that's what I want to dive into with you today and talk about your experiences and how you got to this point. So to start, just kind of tell me, you have really a fascinating background with your perio background, ortho background, going in private practice, not in orthodontics, going back in 2013 to pursue your residency in ortho. So tell me a little bit about that journey and how you've gotten to the point that you're at today.
Sure. Well, I was introduced to interdisciplinary dentistry just being a dental student in Seattle, Washington, pretty early on. Mm-hmm. We had speakers like Vince Kokich and Frank Spear, Dave Matthews coming through and really talking about the power of the interdisciplinary team. So that was a seed planted for me early on. I was exposed to Seattle Study Club early on and really was thinking about the orthodontist role in setting up the foundation. And so when I thought about going to grad school after dental school, and a mentor told me, go practice for a while and figure it out. And I actually worked as Glenn Krieger's associate.
Really? I didn't know that.
For those who know Glenn.
Wow.
And he and I worked together side by side. And through my time as a restorative dentist, our practice was very committed to interdisciplinary dentistry, and also I was going to as many CE courses as I could, as many study clubs as I could. And we had Seattle, Washington has a very high dental IQ. So some of the study clubs I was going to were TMJ study clubs, occlusion study clubs. There were people at that time talking about sleep. And this is back in 2007. This is wow. The interest was really growing. And I just kept going back to watching this interdisciplinary team. Anytime I could see Kokich and Spear and Matthews speak, I was there. And I thought that if I'm going to go back to school, I want to help with the foundation side of dentistry. I want to set up the occlusion. I want to set the bones and the teeth in the right place, and then work with a restorative dentist to finish the case. Yeah. And I thought the breakdown I saw with adults as a restorative dentist had to do with the occlusion, the bone, and the soft tissue. And so I thought, if I'm going to go back to school, I want to do perio and ortho together. That was my dream. And so Penn became a natural next step. And the program there was just phenomenal. And we were working as perio-ortho residents, mostly in the ortho clinic, but also in the perio clinic, and working side by side with perio-pros. And really, I had a lot of exposure to how adults break down. And that has really flavored how I look at the children.
Interesting.
Because so much of the breakdown we see in adults is secondary to some sort of skeletal or dental issue.
Yeah.
And once they're adults, our treatment options are limited.
Yeah.
And oftentimes aggressive and expensive.
Yep.
And so that really flavored how I looked at the kids. And then, to give you another historic context, Dr. VanArsdall, who was the head of our program at Imperial Ortho, he was doing expansion in children and really advocating for this on the podium and in the literature for most of his career. And it's interesting if you look back, because his argument was, we need to expand early to create the bone for the teeth to come into. We need to expand to help avoid gum recession. We need to expand to help for long-term predictability. Expansion does not negate extraction. Extraction sometimes is still necessary, many times because of the AP issues. But getting the width right really helps with the periodontium. And so that was a big part of our foundational learning. We were doing TAD expanders pretty routinely from the first day I entered the program.
Wow.
And we were very well versed in SARPs, and so this was a part of our language. We were involved in a lot of surgical treatment planning, even as residents. And so, because I was there for 4 years, I was able to see these cases over time and to see the retention patients from our faculty, and these cases were stable. When you expand early, when you treat early, these kids that are then come back as teenagers and come back as adults for retainer checks were stable. And so that really was a big, that had a huge influence on me coming out of my program. Then fast forward 2013, I came back to Seattle, and one of my mentors said, there's this phenomenal prosthodontist, he's coming to Seattle, and he's going to speak for 3 days on airway. And I thought, airway, I'm interested in this, but I don't really know much about it. His name is Jeff Rouse, and he has a 3-day course called Airway Prosthodontics. And so I was able to sit through this 3-day seminar. This is before he joined Spear Education. And Mike, I was blown away. I sat in the front row, and it's all these adults, and the last day was children, but mostly adults that all had sleep apnea. And he started talking about some of the signs and symptoms you see in an adult with sleep apnea, wear, erosion, and all the breakdown I remember seeing as a restorative dentist. And what really, really stuck to me is all these adults had malocclusions. And they had malocclusions that I knew how to address. And I knew how to address at a skeletal level in a child. And so that really was such an aha moment for me. And then he spent the last day talking about the children, but a lot of the literature he was citing didn't come 100% from ortho literature. It came from journals like Sleep and Sleep Medicine and Thoracic. And so I had to do a deep dive into the ENT literature and the sleep literature to learn what I was seeking to learn. And so I became involved in a lot more early intervention to try to understand what is the role of the orthodontist on a sleep medicine team. And so I know it was a long answer to your question, but it's been an evolution, and it really started because I saw the breakdown in adults.
No, I love that answer. I thank you for taking the time to go through all that, because I think that frames the background. I think so often people get labeled, right? We love, I mean, just in society in general, but especially in our profession, there's these labels. Oh, you do a lot of early treatment, or you do a lot of expansion young, or, you don't, or you pull a lot of teeth, you're an extractionist, or there's so many things that people label as. But what you're saying is you took a whole composite bigger than basically probably 99% of the orthodontists out there, or general practitioners, pediatric dentists. You saw the end first with all the breakdown, and then you went backward. And Jeremy Manuele, who I had on, who you know as well, who has been doing a lot with Marpy, he said something similar. I thought it was fascinating because, and I said to him, I had kind of the opposite. I started noticing in young kids, just looking at them as I was treating these young kids, saying, boy, I just feel like I'm not treating the cause of their problem, right? So same concept, right? You were seeing people who the etiology wasn't addressed, and you were seeing the ramifications of that 10, 20, 30 years, 40 years down the road. And I was seeing these kids and just had this gut feeling of, because I was newer in practice, I didn't have, I wasn't seeing a lot of adult cases at that point. I was just kind of seeing the kids that came into my office as I had hung a shingle. But I'm seeing these 6, 7, 8-year-olds with these malocclusions, and we'll talk more about this in a little bit, but I didn't really get trained on that. Most of us don't. And so in our residencies, so I'm like, I don't know, but I just feel like they have really small jaws, and I don't think just solving this by pulling teeth is really doing anything to solve the etiology. So that's one thing I love too. The fact that you guys like Kokich, Matthews, I mean, Vince Kokich, what a loss for the profession in so many levels, but I've seen a lot of lectures in my time, going even back to when we were in residency. I remember going to one of his lectures at an AAO and just blown away by, those who weren't fortunate enough to get to see Vince give a lecture in person. He was just brilliant in every level, and how his delivery was just so great. So I try to emulate a lot of what I saw in him when I speak as well. I'm certainly not there, but he just had such command of the material and the audience. It was really great. And then going to UPenn, I didn't know that VanArsdall was that, I was about to say aggressive, really probably not the right word, but progressive would be better, for going in young and helping grow these young faces. I think that's one of the big problems that I see in talking to people about this all the time, and having taught at multiple residencies, that residencies just don't tend to get a lot of young kids in the residency. It just isn't really something that they're just not set up that way. And I think a lot of people, our colleagues, come out of residency, and I know that they've never really treated younger kids. They've screened them like we would screen them, but they don't, because we had the Salzman Index and a lot of them were on state funding, they just can't qualify for treatment. So unless they have a crossbite, you're kind of like, well, I guess we just have to try to see if we have space, maybe some space maintenance, and maybe have to pull some teeth. And because they're not getting coverage, and if it's not a private pay situation, and even if it is, sometimes they don't have the means to be able to do that. So we'll talk more about that, but I've seen that, and I think that's a big problem in our profession, is that, and I think that's why there's some of this academic clinical rift and this big division that I often talk about on this show, is mostly because we're just not trained in it. And I think that's why a lot of the pediatric dentists and even some general practitioners are more open to the idea of treating younger kids, because they've done it. They're comfortable with a 5-year-old in their chair or a 6-year-old in their chair. Most orthodontists, if you ask the average orthodontist, how many 5 to 7-year-olds have you actually performed treatment on from at the day that they graduate from their residency? So for everyone out there, that's 4 years of dental school and 2 to 3 years of an orthodontic residency. I ask the residents when I teach, and most of the time it's under 10. If not, you can count it on one hand. And so if you're not comfortable with the kiddos and the little ones, it's kind of tough to get there if you don't really. I've said many times, I had awesome training in my dental school years from Fred Ferguson at Stony Brook, and he just was just so passionate about it, and really taught us how to manage, especially children with special needs. And I don't think I would have been as comfortable going in and doing what I was doing on 6-year-olds in my own practice without anyone around me, and as I had hung a shingle, if I hadn't had that training. So I think that's what happens. What do you think that? Have you seen that as well?
That's a really interesting perspective. I only know the programs that I've been involved in. So you have much more exposure to academic orthodontics, I think, than I do. I do think University of Washington, we did have a very strong program in pediatrics and in patients with special needs. And maybe it's helped that I have little kids of my own when I have these small kids in the practice. Maybe, I don't know. But certainly practitioners that don't have kids at home can also learn the skill of working with wiggly ones.
Yep.
But we did have a whole a whole course and instruction on phase 1. So that's interesting.
Oh, wow.
I didn't see that as part of our, that's all I ever knew. So I didn't know that other institutions didn't have that.
Yeah, that's the exception from people I talk to. There's some schools out there, there's some pockets where they had some, but for the most part, and as I've been able to try to distill it down, the thing I really think to blame for this is just kind of the economics of it. It's a lot of institutions are in areas where the majority of their patients are coming from state funding or Medicaid. And we know the Salzman Index doesn't count the baby teeth. So, and I think that's why we have this huge debate over treating, like, some people, they actually think it's blasphemous to treat a patient at 6, 7 years old and expand the upper and the lower arches without that patient presenting with a posterior crossbite, even if the arch width is very deficient. And I literally had this conversation with residents the other day and said, take that same patient, right? So you have patient A who presents with no posterior crossbite, but has a narrow maxilla in width and a narrow mandibular arch with caved in lower teeth and a steep curve of Wilson and insufficient tongue space, moderate anterior crowding. Again, we see this all the time. And take patient B, who has a nice level lower arch, flat curve of Wilson, nicer tongue space, no crowding, but has a posterior crossbite. Let's even say it's a bilateral posterior crossbite. My contention is patient A has a more severe malocclusion, even though there's no diagnosis of crossbite. But patient A has a problem in both arches because they have that same width narrow maxilla, but they have a mandibular arch that is compensated. Yet we in a profession say you have to treat patient B young. And there's really not much debate over that. I'm sure there's some outliers, but vast majority would agree patient B with the posterior crossbite should be treated. But patient A, if they don't have a posterior crossbite, what are you doing? And how dare you treat the lower? So talk to me about that. What are your thoughts on that?
Well, we have solid literature to back up what you just said. Miner et al. is a great example. It published in the AJODO that said that you have to look at the bone. And if the bone is more narrow top to bottom, that requires treatment.
Yep.
Irrespective of the teeth. We know as orthodontists, we can tip teeth.
Yes.
So teeth are really not the best indication. I can name other Dr. Tamburino and his team published a great paper on ways to truly measure at the bony level. There, even just the Andrews classification, the Waller Ridge, we have solid literature, and not one paper, but multiple papers identifying. And now with CBCTs, we can really get a sense of the width of the upper and lower jaws.
Yes.
It's not about the teeth. And then if you look at the adult literature, there's a paper that came out, I think 2 years ago. It's 2021 paper.
Yeah.
But it was published in the ENT and sleep literature, Tuller et al., 2021, that correlates a narrow maxilla with tongue-based collapse and sleep apnea.
Yep.
And so now you talk about how does this present in adults? It's not about the crossbite. They didn't correlate it with a crossbite, and they didn't correlate it with it was just maxillary width.
I actually posted that on a social media site, and people were attacking that it was a correlation, not causation. And, we get into that whole debate. But the point is we know it's been proven evidence-based many, many times that adult patients with a narrower maxilla have a higher incidence of sleep-related breathing disorders and obstructive sleep apnea. And I mean, you could say that even correlations can be very powerful when they're true and when they're consistent.
And intermolar width of 30 millimeters or less, they all had apnea.
Yeah.
As measured with the AHI and confirmed with DICE.
Yep.
That's pretty compelling evidence.
I agree.
But I think another big thing that we can talk about as orthodontists is potentially, not always, but potentially avoiding surgery. Because if we think about,
are you talking about otolaryngological surgery or maxillofacial surgery?
If we as humans have deficient jaws, top or bottom or both, we tend to develop compensation patterns.
Yep.
So a crossbite is a great example. You have a narrow maxilla, lower jaw shifts to one side in order to chew and also to speak. Now we have uneven loading of the condyles, and we have compensation patterns.
Yep.
Over time, if that isn't addressed, that patient will continue to have these compensation patterns, and we tend ultimately to see breakdown and or unhealthy growth patterns.
Yes.
Which ultimately, in many cases, will lead to jaw surgery. Mm-hmm. If we can unravel some of those compensations early mm-hmm. with early intervention, it not always, but we hope in many instances, maybe we can avoid surgery. Mm-hmm. And so I think it reframes our mission and our purpose to intervene early. I think our orthodontic community is so hung up on this diagnosis of sleep apnea. Mm-hmm. And I think that is a piece of what we can do, but it's so much more.
Yes.
I think if we focus on health, and health has a number of definitions. So health is tongue posture, health is mm-hmm. lips together, health mm-hmm. is breathing, health is chewing, speech. Speech is so important because it's not just how it sounds, mm-hmm. but it's how we're recruiting our muscles to make those sounds. Mm-hmm. So avoiding lip incompetence, mm-hmm. in avoiding unhealthy speech patterns, and all of these things we have the ability to help with in early children.
Yes. And I completely agree with that. Dave Singh, who was just on the show recently, said, and I told him I might borrow it, orthodontic health is human health. And he said that is a message that we have to take out there to change the mentality towards going into orthodontic treatment with one mindset, which has been the traditional mindset. You know, again, guys like Gianelli, Tunke, brilliant guys, right? And have done a lot for the profession. But in the 90s, early 2000s, they put a lot of literature out there, just really, lack of a better word, hating on phase one and saying that, you know, I mean, Tunke put in an article that if anyone who does phase one is a quack. I mean, it's like, you know, you put things like that out there and people read it, right? Those are in AJODO. It's a major publication. Gianelli was big on focusing on just making room for the teeth. It was all about, can the teeth fit? And there's one major study he had where he talked about you can avoid extraction in 80% of patients if you don't do phase one, but start one long phase in the late mixed dentition. Again, very tooth-based, right? It's all about a debate of, can we make the teeth fit? But that has nothing to do with all of the health-related issues that you're referencing and that Dave Singh and I were talking about, because you're just having an argument or debate on whether or not phase one, you can fit the teeth without phase one, but you're missing so many things. And I think that's where people have kind of gotten divided in these camps. Those are pretty strong words to put in to label people like that. And I think people see that and are like, well, I don't want to be labeled like that. Instead of saying, well, wait. What are we doing with phase one, right? And what is the purpose of this phase one? And to me, that gets back to the diagnostic process and looking at the etiology of the malocclusion in front of us. So what are your 100%. Thoughts on that? Hey everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
100%. Mm-hmm. Absolutely. And so I think as orthodontists, it's fun, it's exciting, it's rewarding to learn more about our role in an interdisciplinary team. And mm-hmm. so here in our community, we work very closely with speech therapists. We work with myofunctional therapists. We work with ENT. We work with sleep medicine. We work mm-hmm. with pediatricians. We work with pediatric dentists, restorative dentists, and really understanding how can we all work together.
Yep.
So take an open bite, for example. Many times, not always, and I think, maybe I'll digress for a second. I think one of the other issues I see out there is it's hard to have black and white statements, yet people get upset because they say, well, they think of one outlier. Mm-hmm. Like open bite, not always, but sometimes open bites are secondary to mouth breathing mm-hmm. and secondary to enlarged adenoids and tonsils. And so mm-hmm. that tongue is coming forward either for lack of space because the arches have developed narrow because of mouth breathing, and or there's adenoids and tonsils at play.
Yep.
And so, yes, we can help close that open and we can debate how we do that. But I think if we don't also identify and treat the adenoids and tonsils, that open bite may come back. The mouth breathing may persist. And then mouth breathing, of course, leads to high caries, leads to gingival inflammation, can lead to downward backward growth, can ultimately lead to further restorative dental needs, periodontal needs, and maybe even jaw surgery.
Yep.
And so I don't want a listener to misunderstand me. I'm not saying that all cases treated orthodontically early will never need jaw surgery. That's
Agreed.
not what I'm saying.
Yep.
But I do think that we have an opportunity, and we have an opportunity to identify some of these unhealthy patterns and try to help resolve them rather than not doing anything and waiting till they're 12 or 13. That's another camp is, well, let's just wait till the adult teeth come in and we'll deal with the teeth then. Even though the 7-8-year-old in front of you has enlarged adenoids and tonsils, mouth breathing, and all these other comorbidities.
Right. And the thing that's hard for me is, again, in residency programs, they're not even teaching that. And I know that because I'm involved in them. They're not teaching anything about airway, adenoids. I mean, they're barely even telling them how to look for it on a Ceph in 2D. Most of these programs don't use 3D. They have 3D imaging, but it's only if there's an impaction, right? They take a pan, they see a tooth that might be impacted, they send them for a 3D. It's not routine. It's not their standard diagnostic records process. So they come out really not trained at all on cone beam or 3D. In the institutions, the radiologists are usually reading it. So the orthodontic residents are typically just getting the radiology report and reading it. So they're not really trained. So one of the things I do when with the residents I teach at Nova is I actually teach them how to read these images, and I explain it to them, and I've built some CE courses for it online so people can start to understand, because I think people are just kind of scared of it a little bit and intimidated by it because they never learned it, right? And it's a lot of structures there. There's a lot of anatomy there when you add that third dimension. That's the beautiful part of it, because you see things you just can't see in 2D. But if you're not trained in it, it can be somewhat intimidating. So how did you realize the value of 3D imaging, and how did you establish some of those connections and relationships between what you were seeing orthodontically when that patient opens their mouth and you're looking at their teeth or their occlusion, and what you're seeing from an otolaryngological standpoint, nasal passageway standpoint, pharyngeal airway standpoint? How did you connect those dots?
Gosh, I think it's just been a journey. I think going back to our residency, so much of our focus was on the transverse. We really spent a lot of time looking at the width and really thinking about the importance of ensuring that the bone on the top was wider than the bone on the bottom in order to get the occlusion to stand upright for periodontal health and for occlusal stability. And so really thinking about taking these measurements early on, you can only gain so from a pan and a Ceph, you can't gain any information about the width. No. And so like you're talking at Penn as well, we had to have a special request for a CBCT, but if we needed it, we could get that information. So for example, when we needed to do a TAD expander, we could justify that we needed to plan our TAD placement. And so, so we had some exposure, but maybe not as much. And then my first practice was a startup, and I rented space from some periodontists, and all I had was a CBCT. Okay. So I was taking CBCTs when I first came out to Seattle as a startup. And once you have it, it's hard not to have it. But like you said, a lot of, especially early on, it was a lot of continuing education I did on my own. Okay. Whether it was online courses or working with the radiologists at Beam Readers to learn as much as I could. Yes. Because you are, as a doctor, you're responsible for understanding what you're looking at and referring when appropriate. And so a lot of self-learning. And then I've learned so much from Audrey Yoon and from the team at Stanford, and thinking about what is the internal nasal valve. Mike, I had to teach myself what is the internal nasal valve and what role does that play in sleep, breathing, and airway and function in a child. Yep. And if you look at Audrey's some of her work and the work out of Stanford, we now can show that maxillary expansion opens the internal nasal valve.
Mm-hmm.
If you look at the adult sleep literature, you'll see that in the ENT world, this is a big area of turbulence. Turbulence in the nasal passages leads to an increase in pressure in the back of the throat, which leads to an increase in collapsibility and potentially perpetuates apnea. Apnea, as an aside, apnea is a we can debate the AHI. We can debate that as our
actually, I'd like to let's debate that a little bit, because that is something I had some somewhat contentious interactions with some people online about. But people can quote, "Oh, American Academy of Sleep Medicine," and they say this, and I know you can kind of pick quotes of people, but ultimately, just so everybody knows, and I want to make it clear to everyone, AHI for adults, right? It's a scale that was developed, and 5 to 15, let's just say, is essentially mild, and 15 to 30 is moderate, and 30 above 30 is severe, just generally speaking. And it's of an episode of apnea or hypopnea, cessation of breathing for greater than 10 seconds qualifies as 1 per hour. For the pediatric population, there are no studies on this. There is no data. They extrapolated the data to apply to the pediatric population. It's one challenge. The other challenge is kiddos are different. They're wired differently. Their sympathetic nervous systems are different, and they're very active. And so it is not super common for them to have an episode of cessation of breathing for greater than 10 seconds, because they tend to squirm or move or brucks or wet the bed, right? So there's all these things they do, which you typically don't see as much in the adult population. So looking at RERAs and overall movement during sleep, which some sleep centers are now doing, obviously starts to paint a bigger picture. But when you're just looking at OSA and you get these studies that just talk about, expansion or early treatment or this didn't do anything for OSA, what are you even measuring, right? So I again, love to hear your thoughts on that.
Yes, and so Dr. Guilleminault wrote that an AHI of 1 in a child cannot be ignored. Dr. Gozel and their group, they talk about sleep disorder breathing in a child can lead to poor school. Snoring leads to poor school performance.
Yes. Decreases in gray matter, even Gozel, I think, had some of his studies show that.
Decreases in gray matter and a learning deficit that they cannot catch up from.
Yep.
That is haunting.
Yep.
Those statements are haunting. And so if the audience that listens to this takes away nothing other than if all we do as orthodontists is screen and refer, that's power in and of itself to help these families find resources. Because if you ask simple questions like, is your child snoring? Have you ever witnessed them stopping breathing? Do they wake up at night? Are they tired when they come home from school? Are they wetting the bed? All we have to do is ask the questions, even if you don't want to treat in your office, no problem. But refer to sleep medicine, refer to ENT, help them find resources. Even if you don't feel comfortable being a part of it, help them. There's a lot of great screening tools out there that can help identify sleep disorder breathing in children because, as you said very well, a sleep study, first of all, it's hard. Access to care is a real problem. And not all communities have access to care for a sleep study. Not all communities have sleep physicians that are trained to work with pediatric populations. Not all sleep centers are set up to do a sleep study on children. Not all insurances will reimburse for it, and it can be very costly.
Not all parents can take their kids to it or are willing to take their kids to one either.
100%. So there's a lot of barriers to getting a sleep study. And once you get that sleep study, there's a lot of debate about how do we read that for a child. So I think using some of the sleep screening questionnaires is a great place to start. We use the Shervin Pediatric Sleep Questionnaire in our practice just because it's very simple. There's others out there that are very, very good. The group, Dr. Zoggy and the group developed the Ferris 6. The Ferris 6 is a great screening tool, and that chart is available for free to download online. And it identifies 6 key things that an orthodontist or pediatric dentist can identify in their chair as a if you have a number of yeses on the Ferris 6, it has a high correlation with sleep disorder breathing. So there's a lot that we can use to screen.
I'll put some links to those in the PSQ and the Ferris 6. I'll put some links in the show notes for those.
That would be awesome. We use them as part of our intake form, just as a point to talk about. And then importantly too, Mike, we use them after. We talk to the families about allergy testing and ENT referrals. And we do our intervention, our orthodontic intervention. But once again, we are just a piece of the team. And when our intervention is done, we repeat our screen. And I think that's a really important piece, whether we start with a sleep study or a screening questionnaire or both. We want to do a follow-up because we want to make sure we continue them on this path toward health. And if we don't have that secondary data, we don't know where they are on that spectrum. We look at follow-up CBCTs, and so you asked another question, how did I learn what to look for? I think any young orthodontist, any established orthodontist listening, try to find your team, find like-minded people in your community that you can share these with and say, hey, I saw this on the x-ray. What am I looking at here? You saw this patient clinically. I think that's a deviated septum. Is that a deviated septum? Is this what enlarged turbinates look like? When would I refer to treat? Anytime I see something funny, anything unilateral, right away I'm calling my ENT. I've learned to identify something called silent sinus syndrome, which I didn't know what that was before I started working with CBCTs. And so really just taking the time to look through these images and ask a lot of questions. I read another phenomenal book called Rethinking Rhinoplasty by an ENT named Howard Stupak, and I couldn't put it down. And it's so interesting because it talks about growth and development of the nose and how the nasal passages are so intimately related to the maxilla, and how mouth breathing early on in childhood impacts not just the growth of the maxilla, which is what we see, and maybe we see crowding, but he talked about the deficiencies of the growth of the nasal passages, the potential link with a deviated septum, things like a dorsal hump and lack of support of the nose as the upper jaw drops down and back. Unbelievable when you read some of these things. And then he goes on to talk about the differences in ENT intervention and a lot of the evidence-based or lack of evidence-based information we have with ENT intervention. And so we as doctors, we really have to educate ourselves in some of these areas and really ask a lot of good questions. And can take that a step further, push our institutions to educate our residents on this, because they need to come out educated on this, because obviously continuing education and practice is practice for a reason. You're learning as you go, but these are fundamental concepts. Everything you're saying is 110% correct in my opinion. But I know that when I started looking at this, I say all the time, once you see airway, you can't unsee it. It is when you start to see it and you have a parent break down in front of you in tears because you are the first one to ask them the questions that are honestly questionnaire, or when you notice that, you see some of that turbinate hypertrophy or some moderate enlargement of the adenoids or restricted oropharyngeal space, narrow arches, insufficient tongue space. They came to you for maybe just because there wasn't quite enough room for their lower laterals to erupt, right? I mean, and you're having this conversation. I want to mention that because I think a lot of people, I used to have, before I got known as someone in my community who thought this way, because in time you get known as somebody who thinks this way. And then people start to come to you because they tell others and they're literally like, oh my gosh, Dr. Becca, like I went because, Susie had some crowded teeth. And next thing I know, she's the one who figured out why she was snoring, right? I mean, that's literally what happens when you start looking at your patients this way. And so aside from the fact that obviously is very, tremendous for your reputation in a community, you're helping kids in a way well beyond what you can do with just straightening some teeth out, as wonderful as that can be. In addition, I think that where people get that, so one obstruction is teaching residents coming out. The other is the stigma, and you alluded to it a little bit.
which is OSA, right? That if you do this, you're diagnosing obstructive sleep apnea, right? And that couldn't be further from the truth. You are recognizing the signs and symptoms of a sleep-related breathing disorder. And that is within the purview. And I had Eric Plumas on the podcast a little while back, who's an attorney and orthodontist, brilliant guy. And we talked about it is within the purview of orthodontists. He's like, from here to here, neck to, forehead, anything there. It is our scope of practice. And I think sometimes, I don't want this to come out the wrong way, but I like to be honest on this stuff. I really do think that some people are just intimidated by cone beam, and it almost has more information than they're comfortable seeing. And that can be hard. That can be hard because it can be scary, right? If you're comfortable looking at 2D images and you're getting pretty good results with your cases, it's really easy to say, yeah, this stuff is kind of crazy and outlier. But what's interesting is you look back over 100 years. I mean, Engel talked about mouth breathing being one of the biggest causes of malocclusion. And guys, Bogue and Holzman and people throughout the early part of the 1900s were talking about the relationship between airway and breathing and malocclusion. And we're also very proactive on starting to treat kids even younger than we do now. Bogue had a whole book on going in and treating in the primary dentition. So, this is not new. This is not fringe. The science is there in the medical and in the dental literature for this. So with all of that, what would be your advice to colleagues who hear this or who hear someone talk about going in young on these patients? And for now, we'll say, which I'll come back to in a moment, the whole 7-year-old thing, but let's just call it like 7-ish, right? For now, we'll just kind of stay within the traditional orthodontic philosophy and say, you know what, Mike, Becca, you guys are just this. There's no evidence for this. There's nothing. You guys are just literally outliers on this, and you're just doing this for your own profit or whatever people say about this. What do you say to that? Do you have questions about a clinical case, or maybe a challenging practice management issue? Or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice. Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
I don't agree with that. I think we are, it's orthodontics and dentofacial orthopedics. That's us.
Yes. Yep.
We help guide growth, and terms like adenoid faces.
Yes.
And like you mentioned with Dr. Engel, we have known this for a long time. Mm-hmm. And I think we can reframe the definition of phase one. Phase one is not just upper brackets on the upper front 4 teeth. Mm-hmm. It's about what can we do to help guide skeletal growth and development. Mm-hmm. We can reframe our endpoints. We can reframe why we are intervening. Mm-hmm. And of course, we're not going to treat if there's no issue. Of course.
Thank you for saying that. Yes.
I mean, if the child doesn't have a malocclusion or a skeletal deformity, right, of course we're not going to treat.
Right.
If they have a sleep disorder and they don't have a skeletal issue, we're not going to just expand if the kid is deficient. And I think that's really where people get this bad rap.
Yes.
I think we have this amazing opportunity to identify things. Like you mentioned, they may come to us because I have a great, I don't think I can share it with you, but because I'm on the wrong computer, but I had the child that was referred to us for an impacted canine. Impacted canine literature says impacted canine highly correlated with the narrow maxilla. Mm-hmm. Expansion is one way to avoid an impacted canine. Mm-hmm. That is established. Mm-hmm. And so here I have this impacted canine. I take a CBCT. Adenoids and tonsils, Mike, are almost 100% obstructing.
Yep.
She's 11. And I start asking questions to mom, and there's a history of hyperactivity. There is a history of daytime fatigue, history of snoring, history of bedwetting, and it goes on and on. And so now we can show this to mom. And so yes, orthodontically, it's expansion and probably taking out the primary tooth, but it's also referral to ENT. Maybe it's referral to sleep medicine. To get that diagnosis, but it's helping this family understand what we're seeing. And so could could you say that a lifetime of mouth breathing led to low tongue posture, which led to a narrow maxilla, which led to the impacted canine? Maybe, maybe. If we had gotten adenoids and tonsils out younger and established a breathing pattern with lips together and tongue up and had really great growth without any orthodontic intervention, could that have helped this kid? Maybe. We don't know. Could we have expanded early and avoided impaction? Maybe. But so this is where it becomes a team approach, truly. But an orthodontist has a seat at the table.
I think the orthodontist is the quarterback. And that's one thing with the AAO's white paper that I struggled with so much, is that removing us from that response. We can handle it. We are trained, as you said, as in craniofacial growth and development, as well as anybody in any medical or dental arena. It's our wheelhouse. We are not just tooth straighteners. We don't just line up teeth with plastic, right? Like that, doing that in some cases, of course, but that is not the genesis of our specialty and of our training and of our ability. And to relegate us to just debates on whether we can fit the teeth or extraction and non-extraction, I think is really shallow and misses the point of exactly what you're saying is, let's look at the patient as a systemic patient, orthodontic health, human health, their overall relationship, because what they're coming in with are symptoms. And it is well within our purview, as you said, especially if you understand 3D imaging. And I strongly encourage those who might be skeptical about that to do the work to figure that out, because it, as you said, once you see it, it changes how you approach everything in terms of your practice and your patient care for the better. But why do we still have such heated debates when everything you're saying, I have seen myself? And oftentimes I say to somebody, I almost feel bad that you've never changed someone's life that way. When someone is really against this approach, I just wish they had one patient they could feel what you just said you did with that 11-year-old girl. Because once you do that once and you change the trajectory of that girl's life, it's not about the canine, as you said very well. The canine is the symptom. It's probably the symptom of the symptom of the symptom, right? I mean, it's down the line. You detailed it beautifully. It's down the line of reasons why we are where we are. It's what we tend to focus on in our profession, that impacted cuspid. But let's go back. Why is it that way? And now, step back. Could we have gone in young on this patient? Because I can tell you, the patients that came in narrow, mouth breathing, adenoid obstruction at 6, 7 years old, that I got to the ENT and or allergist if they had terminal hypertrophy and allergies, and did expansion young and got room for the tongue, and they turned them into nasal breathers, I almost never saw impacted canines in those patients. And if I did, it was literally just a malformed, one of those canines that's horizontal. It's up under the orbit, it's just developing horizontally. It's just never, it's a genetic anomaly of that tooth. But when I would go in on these kids, everything just developed beautifully. And so it saddens me that there are so many patients out there that don't get the benefit of that treatment because so many orthodontists don't believe it.
Yeah, it's unfortunate. Well, and I guess, and so I'll make one more point about the adults. We know it is well established that MMA is the gold standard to treat moderate to severe sleep apnea in an adult. It has a better long-term success rate compared to CPAP over 5 years. Because people aren't adherent to CPAP, and CPAP is a BandAid.
Yep. Right. Treating the symptom. Absolutely. Yep.
Yeah. If we can positively impact the airway in an adult by bringing both jaws forward and making the upper jaw wider, why can't we help with the kids?
I'm so glad you said that. I mean, literally, that's like mic drop. Like what? I can't think of an explanation for why someone would say that that's not the case.
So I don't understand the people that don't believe that there's power in this.
Yeah.
And so I think, like you said, I think our community gets so hung up on this diagnosis of sleep apnea and whether or not we can cure sleep apnea. We no one's saying that we can.
No. Right.
Nor do I think that we can. We're not in a vacuum, and sleep apnea is not. First of all, it's not the best endpoint. And also that's not the goal. The
Right.
goal is to establish a healthy craniofacial system.
Yes.
To establish health and so we need to, as a profession, define what is health,
Mm-hmm.
and think about who do we need on our team to help get us there.
Mm-hmm.
And skeletal shape and form is part of that. Occlusion is part of that.
Mm-hmm.
And it doesn't matter how, like whether it's plastic or brackets or expanders or herpst or
right.
That is not as important at how we get there. Yep. But I think we have an opportunity, and we have an opportunity to reframe what we think of as phase one.
Yeah, and that reframing phase one, and I don't mean to keep harping on this, but it's just obviously it's something I'm very passionate about. You're a perfect example of that. You got trained in this to think this way in your residency, right? A lot of orthodontists who didn't won't ever think like you are. I think they will dig in and feel that there is no place for it. Some are willing to see and change and evolve in that. So I really do believe if the profession, including the AO, went and really worked with our residencies to get them doing cone beam as a standard, right? Understanding airway, talking about the research and the literature and the data from the medical side and the dental side, understanding the history, everything we have been talking about this past, 45, 50 minutes. If they could implement that into the programs, I would be shocked. I mean, the missing piece is they still have to be able to get young kids to be able to treat. And that is a challenge. And I really don't know how to solve that part. But at least if we start to teach it, train it, and talk about it, I think people will come out much more open to it. I think once you've been doing something in anything in life for a long period of time, to think that you could have been doing it better is kind of hard. I know for me personally, when I came out, I just had this feeling I shouldn't be sending these young kids for a bunch of extractions when they were really narrow and constricted and didn't have big teeth. They had small arches. And so I got involved in treating it. But as I went through, there was a progression in how I did that and how I changed. And I was constantly having to reevaluate and look and think, boy, I wish I'd knew this much more, 3 years ago, because some of those cases, I could have saved them a lot of time, energy, and headache, or saved myself and my team, et cetera. You have to be willing to critically evaluate yourself and not be so hard on yourself to say, if I do this differently, then the way I did it for 20 years is wrong. No, it's a part of the process. And I just wish more people were open to it. And what you said, but I think it does get kind of daunting because, as you said, if you don't have, in our schools, again, you've got everybody under one roof. Let's teach them how to work with the ENTs and the allergist and understand how to coordinate that care in a residency program would be so wonderful, because then you're not intimidated when you come out. It's kind of intimidating for a lot of people to just call the ENT. I happen to had a lot of allergy issues myself, so I knew the ENT and the allergist very well. So I had friends in that arena already, and I started to pick their brains. And then being involved on the cleft craniofacial team, it was just a natural for me just to start to say, hey, I'm doing these 3D things now, and start to look at those more critically. So that's how I was able to develop those connections. But I think a lot of people aren't just going to pick up the phone and call the ENT down the road and say, hey, can I send you patients, when they maybe not have the confidence to even know what they're seeing. And I think that gets back to our training, right? I mean, you had a level of training that gave you the confidence, and you pursued even more training with all the CE you went to early in your career to feel comfortable and confident having those conversations. So what other ways, since that's not going to happen overnight with our residency programs, how do we get colleagues to embrace this concept, understand this concept, and not look at it as some outlier philosophy that shouldn't be given its due? Have you heard about the Doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off Doc educational materials. Just go to Facebook and search for the Doc community and submit a request to join the group. And now back to the podcast.
I think what you're doing with this podcast is a great first step. I think increasing awareness. Mm-hmm. I think people are going to continue to publish. And so being really excited about new literature that's coming out, maybe giving exposure and light to papers that have been around for a really long time, that we just that are just not commonplace in, for example, what we read in our literature, in our residency programs. there's great articles in Angle and AJODO and in a number of our professional journals.
Yes.
And it's growing and it's coming and it's exciting. And to keep understanding what it is that's out there that's emerging in the field, and to not shun our colleagues, but to be excited.
Yeah.
And to really be excited about what's out there and to work collaboratively. What, probably 20 years ago, there were pockets of people that said, you're not a real orthodontist if you're moving teeth with plastic.
Right.
How dare you?
Right. Yeah.
And now every orthodontist is using aligners to some capacity, I would venture to guess.
Mm-hmm.
And if only we can be more collaborative and more supportive and cheer each other on and say, hey, what are you doing in your practice that's working?
Mm-hmm.
What have you done that isn't working?
Mm-hmm.
And let's talk about it and let's learn from each other.
Yeah. And I would encourage too, I think another big piece of that is if the private practice orthodontists, those of you out there listening who agree with Becca and I, who have seen this, who have changed lives with this approach, who have connections with your colleagues in the medical arena, go give a lecture at a residency, talk to residents. If you work near an educational program, volunteer even once a month, right? Or just twice a year, go in and give just try to get some exposure, because as I've talked about on this platform a lot, there is definitely this clinical education academia divide. And that can't happen. That when you have a divide, a big rift between your academic institutions and your average clinical practitioner, and they look at one another as almost adversaries, like, well, you do the way they do it, or the way you do it. I've heard directors say in the past, everyone that leaves here, they go out and they forget everything and practice the wrong way. And so there's this edge. And I feel like that is really damaging to the profession. And I think that can be healed by private practice orthodontists who see what you and I see, do what you and I do, going in and spending some time with the residents and the directors and saying, hey, look, this is what I'm seeing. And I think because maybe you can't get the patients at 7, right? And kind of finish with talking about that a little bit, but it's you can't get the patients at 7 and you don't have a big patient pool that age, or because you treat a lot of state-funded patients and they can't get coverage for that. Let me show you how I treated some of my cases. Or maybe the residents I used to have when I was in upstate New York, I ran the orthodontic side of a GPR, and I would have the residents come through visit my office and spend time in my office so they could just get a feel. And they were general dental residents, but just so they could understand referral patterns and understand what to look for and what I was actually doing in there, versus me just giving some lecture. So try to set those programs up, because once those residents, and these were again GPR residents, a 1-year GPR, they would see my cases and what I was doing early, and they're like, wait, you can do that on a kid that age? And I'm like, yeah. Or I'd be looking at airway and they're like, how did you know that they had a sleep problem? They come in the consults with me and watch these parents blown away by the fact that I would uncover these airway issues and understand the exact example you just gave with that 11-year-old girl. And I think it really resonated with them to where they realized what was possible, and then it makes them not quite as intimidated by it. So that's kind of my plea to all our colleagues out there who do this. There's a lot of kids depending on us who aren't getting the treatment that they might get in a practice like yours or mine, and there's an opportunity there. So kind of to wrap up, why do you feel we are stuck on ages as like 7 is the age, right? I mean, AO, all kids should have a checkup by 7. Where does that come from? What are your thoughts on that? I'll just full disclosure, I never got into treating patients much younger than 6. I just didn't get them really. Again, the patterns aren't really set up for them to be referred to me by that age. I treated many 6-year-olds at that point and went in and helped expand and grow and develop. But let's talk a little bit about why 7 and what some people are doing and seeing to kind of push that envelope even younger.
I think this is a big contentious area. I think, like you said, the AO says by age 7, but there's never been any studies that 7 is this magic number. My best guess, Mike, is that we historically have bands that fit on first molars. So we had to wait for the first molars to come in, so that our appliances would fit. Today with 3D printing, we can 3D print a band to an E, no problem. So I think that really isn't the gold. That's not the benchmark, at least in our practice today. I think it has to do with behavior for me. If there's a true skeletal deformity and the patient has a functional deficit secondary to the skeletal deformity, such that waiting another year or 2 or 3 could otherwise potentially lead to further and further unhealthy growth, why not treat? We know that, for example, an underbite, a maxillary deficiency, maxillary hypoplasia, if we can get that face mask in at age 5, 6, 7, it's way easier and more predictable than if you wait till 8 or 9. 8 or 9, that's dental alveolar. That's not skeletal. To the same degree. So why not?
Right.
I think it's behavioral, maybe, for patients. And so you brought up a really interesting point that I never thought about, which is, are we trained in handling and working with kids? But I think 3D technology has really been a game changer, because today we can scan, we order the appliances, and with some glass ionomer cement, we glue it in. That's a quick appointment. It's an easy appointment, but it's patient selection. And like you brought up at the beginning, it is imperative for us ethically to not overtreat. And so we're making sure that we're choosing these patients. If they truly have an orthodontic need that can't wait, then we make a call to consider intervention early. We're not overtreating. We're trying to understand what is it that can't wait. And so that's true for all phase 1. If we see a 5, 6, 7, 8, 9, 10-year-old, and we think that they have a malocclusion or some deficit that is so extreme it can't wait, then it warrants treatment. But if it can wait, then wait. And treat when they have all their permanent dentition.
And at the very least, if you see them younger and you take a cone beam on them, you might detect obstructed nasal passageways and just say, hey, you need to go see the allergist. Or you might detect those enlarged adenoids. I mean, I literally earlier today got a haircut, and my barber was saying to me, talking to me, he was saying something. He knows I have the podcast, and he's like, hey, and I'm saying, oh yeah, I got the podcast coming up and today, and he's like, oh, it's going to be on. I was kind of just giving him a little brief, and he goes, oh, I have obstructive sleep apnea. And I said, really? And he's like, yeah. And they gave me a CPAP, but I hate it. And he said, my brother, who he co-owns the barbershop with, he's like, he does too. His is really bad. I mean, I think his brother, he said, scored like a 80 something on the AHI scale, like off the charts. And he said he was a 38. And I said, what about your kids? I know he has young kids. And he said that two of them, young, one at 3, one I think at 6, ended up needing their adenoids out. And so we kind of got in this discussion of how I said, wow, your pediatrician did a great job on the 3-year-old, because a lot of pediatricians won't even really make that referral. Like, that's a whole nother discussion and obstacle, right? A lot of the pediatricians in certain areas just don't believe in that. And he said, that's so funny you say that. And it turned out, ironically, he's also from, I'm down in South Florida now. He's also from where I live in upstate New York. And he took his daughter, who was helped by this, to the ENT that I was on the cleft craniofacial team with. And we just got talking about that. And he said, it was so weird. We moved down here and my other child was snoring and going through all the stuff that my other one was. I took her to the ENT, and the ENT was like, no, they haven't had strep 5 times, and didn't want to do it. But now dad was an educated parent, and he said, I know what I've suffered with. I know that my other daughter stopped snoring right away after that she had her tonsils and adenoids out. So dad fought for it and went to another person, and that person ended up saying, absolutely, she needs it. And he's like, and she went in and they did surgery on her, and she's doing great. So even if we could be that person, that advocate for those kids, because he was lucky that he had the person he did up in upstate New York, and then it prompted him to push for it down here in Florida. But that being said, it was just the luck of the draw. The person he happened to choose, or that was referred to in Florida, wasn't going to do it. And it was only because he had experienced it before. The second person was like, absolutely. So if we're there as, again, the quarterback, as the orthodontist, and we can say, hey, even if it's at 3 or 4, even if we're not going to do anything orthodontically, but the radiation levels on these CBCTs, the pediatric dose is so low, you take one, you figure this out, and you say, hey, are they snoring? Are they a restless sleeper? Are they having these issues? Yes. And at least at that point, you're doing something to help, again, treating the human, not just focusing on the teeth.
Right. And so what we do in our practice, if they're under the age of 5, or if they're 5, we'll bring them in and we do sort of a chairside meet and greet, and we get a sense of what the parents' concerns. We go through the pediatric sleep questionnaire, and we just talk, and it gives us a chance to look at behavior, take a look inside the mouth. Most often, we're not even taking a CBCT for those little ones. We're not taking photos. Just a chance to talk to the parents, and we're most often referring for ENT, allergy, sleep medicine, and many times also therapy. And then we just bring them back yearly. And like you said, we become like the quarterback. We're trying to help them find resources, and that in and of itself is a service to our community. And it's not putting an expander in. It's just being a resource,
right?
And because we see it, and even if they have a malocclusion, they might not be ready for treatment,
right?
Maturity. And so that's how we approach it. Even 5, 6, just trying to get a sense of what is it that they truly need. Is this something that can wait? Do we wait on this? Do we watch it? Do we watch it for 6 months, a year? Who needs to come first? That's another important piece when you work with your team. If you have a skeletal craniofacial issue and you have enlarged adenoids and tonsils, maybe you have a tongue tie, maybe you have speech issues, maybe there's an audiology issue. Who comes first? Allergy, and how do you work with your team? And that's really a key piece as well.
Yeah, and developing all these things takes time. So I know some people are going to listen to this, and it can sound kind of overwhelming. If you haven't had training in this arena and you've never treated young kids and you've never worked with medical colleagues, and I think that's again where these walls come up and people just are like, no, there's nothing that says this works, and I'm just going to stick to treating the 11 and 12-year-olds. If you don't want to do this, and Stacy Ochoa and I've talked about this a lot of times, like if you don't want to be treating kids super young, that's okay. It doesn't make you a bad orthodontist, but just there's no need to discourage others from exploring this and trying to help these kids, because it can be life-changing. So to finish, talk a little bit about that side of it. Talk about why you're so passionate about this, and what, whether it's just specific stories or generally speaking, what has this done for you to be able to provide this service for your patients?
I think like you saw just that joy, that elation when you and the parents realize that the kid isn't snoring anymore, that they're sleeping through the night, that they came in with an open bite and now they don't have an open bite, or we've dramatically improved the life of not just the child, but also the family. And it gives meaning and purpose to practicing beyond just alignment. It's fun. It's fun. It's invigorating. No case is easy. No case is straightforward. Every case is interesting and challenging. And it's true with that. We didn't even talk about teens and adults and all the things we can do, but it's fun. It's exciting. And talk about lifelong learning. The breadth of knowledge and the areas that we can continue to learn is there is no end. Whether we start, like you said, you can go to CE that's ortho specific. You can also expand your knowledge base, whether it's radiology and CBCT, or learning more and more about ENT and what's out there, what causes sinusitis and why, and what type of ENT surgeries are available. Things like hypoglossal nerve stimulation. I don't know that every orthodontist has heard of that. And what's the role of a MARPE or a TAT expander in your practice, and how does this play a role? MMA, how do we do it? Is there a right way? Is there better ways? What's the new technology when it comes to jaw surgery? There's so much to learn, and that's invigorating. That's exciting.
Yeah, I completely agree. I'm glad you said that, because it's really ironic, because it seemed like 10 years ago when aligners were becoming very prominent and over-the-counter aligners, there was all this talk of like, our specialty is going to go away and you're not going to need orthodontists anymore because, it's just these over-the-counters are going to replace us. And I actually think 180 degrees different from that. I think we have so many unexplored opportunities with our knowledge and training to be able to impact lives so much more than just what an over-the-counter clear aligner can do, right? That it's such a shame. It is such a shame to focus on that. I mean, because we need to be aware of those things. They're relevant in our profession, but let's turn inward and say, instead of focusing externally on these external threats, let's look at ourselves and say, how can we be lifelong learners? How can we grow our profession and our craft and our trade and the science of what we do to impact lives on a greater scale? And I think if we all can just agree on that, the way we do it, as you said, whether you use this appliance or that appliance, great, we can have those debates and we always will. But I really one of my biggest goals is to try to get people to come together in our profession to see the power of what we can do to change people's lives beyond what we were likely taught or maybe knew we could do.
Absolutely. Absolutely.
Yeah. Well, Becca Bockow, thank you so much. I really enjoyed it. You are such an expert in this arena and an inspiration. And I mean, you've taken some arrows. I know. I give you tremendous credit for your courage. You started speaking on this publicly before I did. And you've made it easier for those of us who have also tried to stand up for this and be vocal on this. But you were clearly doing this before it was sort of more mainstream as it's getting. And you're a voice for people who maybe are scared to, but hear you. I know multiple people who, after hearing you speak, have thought completely different about this topic. And that's changing lives, not just of our colleagues, but through their hands and abilities of a lot of kids and patients for that. So thank you for what you do and for taking the time to be with me on the Doc Podcast.
Well, thank you. And thanks for getting the word out too. Thank you.
My pleasure. Great. All right. Take care, Becca. Thanks so much.
Thank you.
Bye. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.